Good morning, everyone. We're excited to get started. It's 10 o'clock on the dot, so let's go. My name is Kelly Cannon. I am the CEO of the VHHA Foundation. On behalf of our entire team, welcome to today's webinar on rural health transformation funding opportunities for remote patient monitoring and graduate medical education. We are so encouraged by the strong interest from hospitals and health systems across Virginia to participate in rural health transformation. These opportunities represent a significant investment in rural healthcare and in the communities our hospitals serve. Virginia's Year One award of $189.5 million gives us an important opportunity to improve access to care, strengthen the healthcare workforce, support innovative technology, and advance better health outcomes across rural communities. Today, we'll focus on two funding opportunities administered by VHHA Foundation: remote patient monitoring through Care IQ and graduate medical education through Homegrown Health Heroes. Our goal is to walk through the application process, the eligibility requirements, the timelines, the available technical assistance, and what we hope to achieve together over the next several years. From the get-go, what I want to say is we view this as a partnership. Whether your organization has a program ready to scale or is still exploring our ideas, our team is committed to providing guidance and support throughout the process. So thank you for joining us today and for the work you do every day for your patients and to the strength and the health of your communities. First, some housekeeping. This webinar is being recorded. Anyone who wants to revisit the information or share it with colleagues will be able to do so. We will post both the slides and the recording on our website after today's session. We welcome questions throughout the webinar. Please use the chat, and we'll address as many of those as we can during the dedicated Q&A at the end. You'll also see the required Stevens Amendment disclaimer here, which reflects that this project is supported by CMS through HHS as part of the Rural Health Transformation Funding Award. So first, we're going to dive in and talk a little bit about who we are. Many of you are familiar with VHHA, the trade association that represents all 27 health systems and 118 hospitals in Virginia. You may be familiar with our data and analytics department, the quality and safety team, our legal team, our advocacy initiatives, the emergency preparedness efforts that our team leads, as well as our workforce initiatives. The Virginia Hospital Research and Education Foundation is an affiliate of VHHA, a 501c3 independent organization that operates a number of grant initiatives related to violence intervention, population health, community health workers, substance use intervention, and rural health. We're very excited to partner with the Commonwealth and to be selected as a key implementation partner for two initiatives of this year's Rural Health Transformation. I want to give you some faces behind the names that you will be interacting with over the next several months and years. Here's our VHREF team. Everyone is playing a key role in rural health transformation, is excited to support you in these initiatives. A key role that VHHA Foundation plays to support our members is grants administration. We aim to take on the burden of grant administration and let you all focus on what you do best, which is providing care to your communities. So part of why we are a key partner for the Commonwealth is that we've developed strong relationships with each of our members. We can offer fast and efficient contracting. We can provide programmatic and operational support, and we'll help you with building sustainable programs. We want to make sure that this is a great experience for all of you, and we are here to support you every step of the way. That being said, VHHA is also your trade association. You are our members, and we want to make sure that we're providing member-focused support. So not only will we be supporting you in remote patient monitoring and graduate medical education, but we're also going to make sure that you have every opportunity to participate in all the initiatives related to rural health transformation, including those that our team is not administering. So we're going to be here to support you in connecting with the implementation partners for other initiatives, making sure you get your questions answered, supporting you as you prepare your applications, legal support if necessary, data that our analytics team can provide. We're going to be here for you every step of the way. Moving on to a quick overview. I think all of you are quite familiar with rural health transformation. And to set the stage, this was established as part of the federal legislation of H.R. 1 and is designed to strengthen rural healthcare systems nationwide. The program represents a historic investment of $50 billion over 5 years across all 50 states. Every approved state receives a base allocation of approximately $100 million annually. Additional funding is distributed based on factors such as rural population, state policies, and the strength of a state's application. Virginia was very competitive in this process. We received a year one award totaling nearly $190 million. The scale of this investment creates a unique opportunity to improve access, workforce capacity, technology adoption, and health outcomes in rural communities across the Commonwealth. Virginia's Rural Health Transformation Program is built around 4 major initiatives that work together to strengthen rural health systems. Care IQ focuses on technology innovation. Homegrown Health Heroes is centered on workforce development, helping grow and retain healthcare talent in rural Virginia. Connected Care Closer to Home focuses on expanding access through innovative care delivery models and reducing avoidable emergency department utilization. Live Well Together emphasizes prevention, chronic disease management, healthy lifestyles, and community-based interventions. There are multiple statewide partners leading and supporting these initiatives, bringing together expertise from healthcare, education, workforce, and innovation sectors. The key takeaway here is that this is not one standalone project, but a coordinated statewide strategy that is supported by a 5-year investment. Diving in a little deeper, this is a higher level overview of the types of project and visions under each initiative. This slide provides more information about the designated rural health regions in the Commonwealth's application. These were designated as the Federal Office of Rural Health Policies, rural regions. Those that are solid are designated as rural regions. Those with diagonal lines are considered non-rural. This map, applicants should pay close attention to how their organization serves rural communities within these regions. Of note is that the physical location of a facility is not the sole determination of eligibility for rural health transformation. Our team is prepared to work with you. We were happy to have individual conversations to discuss the patients that your facility serves, the rurality of those patients, and your eligibility for various initiatives. There is not necessarily a one-size-fits-all answer to whether or not you are eligible for rural health transformation as a whole. We are happy to discuss in greater detail offline the patients that you serve, the communities that you represent, and whether or not you may be eligible for funding. We want applicants to know, as we discussed earlier, that support is available both before and after award decisions are made. So before the awards are issued, we're going to provide informational webinars like today's session to explain the requirements, timelines, and application expectations. We'll also provide one-on-one consultation opportunities with the RPM and GME teams to discuss your project concepts, procurement questions, eligibility, and other concerns. Following award announcements, successful applicants will participate in an onboarding process. That we'll cover in greater detail at that stage: reporting requirements, compliance expectations, audit readiness, and financial administration. We'll continue to offer individualized technical assistance throughout the life of the grant and intend to foster peer learning opportunities so that you can share lessons learned, successful practices, and solutions to common challenges. The bottom line is we want applicants and awardees to succeed. Our technical assistance is designed to help turn strong ideas into successful and sustainable programs. With this, I'm going to turn it over to my colleague, Heather Neal, who is our program manager for remote patient monitoring, to dive into our first program. Thank you, Heather.
Thanks, Kelly. So good morning, everyone. My name is Heather Neal, and I'm the program manager for remote patient monitoring. Today, I'll provide an overview of the RPM funding opportunity, including eligibility requirements, program expectations, and key considerations to help you develop a strong application. So our RPM team is here to help you throughout the process. I'll be your primary contact for questions related to program requirements and project development. Vicki Humphreys, who you'll meet later, is our grants administrator. And we also have Mary O'Connor and Adrian Hill, who provide expertise in population and community health and are available as resources. So Care IQ advances CMS's technology innovation goals by helping rural providers adopt digital health tools, strengthen chronic disease management, and modernize care delivery models. Successful RPM programs integrate technology, workflows, training, and patient engagement to support data-driven care and better outcomes. For year one, the total funding amount is $14.3 million. Year one is structured as a pilot phase with an anticipated 2 to 3 hospitals. Our focus is on identifying and contracting with rural providers that are ready to implement or expand RPM, supporting vendor vetting and procurement, aligning workflows, integrating data, and evaluating both technology performance and payment model considerations. From the outset, your project should be designed with long-term growth and sustainability in mind. So years 2 through 5 are intended to build on lessons learned from the year 1 pilot. Estimated funding across the full 5-year period reflects a larger scale up in the later years. Our goal is to continue program support and grant administration, monitor and analyze performance measures, and scale the program to include additional hospitals, federally qualified health centers, rural health clinics, and independent providers. For year 1, eligible applicants are hospitals and health systems that are licensed or authorized to provide healthcare services in Virginia. You must operate in or provide direct services to federally designated rural Virginia communities. You must have an active SAM.gov registration with a current UEI, no active exclusions, debarments, or suspensions, and the demonstrated capacity to manage federal funds. Vendor, care management, and other partnerships are allowed, but your organization must remain the lead applicant and fiscal recipient. And projects should support new RPM implementation or program expansion and should not duplicate programs funded elsewhere. So the next few slides outline some of the anticipated required application elements. So this is a list of the required activities you should be prepared to address in your application. A strong proposal will include the purchase and deployment of appropriate devices or technologies, a clear plan for integrating RPM data into clinical systems and decision-making, define workflows for patient monitoring, and staff training and operational support. You should also describe how you will engage and enroll eligible patients, coordinate with providers and care teams, and track, report, and evaluate outcomes. Your application should speak to program sustainability and alternative payment models. We are looking for projects that can move beyond the pilot phase and become sustainable components of routine care delivery. Here you'll see the required milestones. You'll be asked to provide estimated completion dates for each of these milestones, as well as any additional project-specific milestones relevant to your program. These milestones cover program workflows, staffing, device deployment, EHR integration, patient enrollment and education, sustainability planning, and program evaluation. As you develop your proposal, consider how key activities and milestones align throughout implementation. And together, these milestones should provide a clear roadmap for implementation and demonstrate your readiness to successfully execute your project. These are the required metrics for the year 1 performance period. These measures are intended to capture device utilization, clinical outcomes, and patient-centered outcomes, in addition to any project-specific metrics that you have. On the utilization side, you'll report on patient outreach and enrollment, device deployment, and adherence to transmission schedules. From the clinical perspective, you'll track condition-specific metrics related to your RPM use cases, along with ER visits, readmissions, and hospitalizations. And from the patient perspective, you'll measure their satisfaction and confidence in managing their condition. And together, these measures will help demonstrate the reach, effectiveness, and overall impact of your program. The broader impact of this initiative is to improve rural patient care while supporting sustainable RPM adoption and expansion. Sustainability includes integration into routine care, staffing and operational stability, billing and reimbursement strategies, future funding sources, continued partnerships, and ongoing maintenance of the technology workflows and care models. So statewide, the program aims to increase RPM adoption across rural healthcare settings with a target of at least 90% adoption or a 10% increase above baseline in each of the 6 rural health regions by 2030. And these are some examples to highlight the range of potential projects. Projects could focus on postpartum hypertension monitoring, diabetes management through continuous glucose monitoring, system-wide multi-condition RPM programs, or integration of community health workers to improve literacy and adherence. Competitive proposals will connect a defined rural need with implementation readiness, measurable outcomes, and a sustainable model. So with that, I've reached the end of the RPM overview, and I'll turn it over to Kayla to discuss the GME program.
Good morning, everyone. I am Kayla Diggs-Brody, the Program Manager of the Attract and Retain Physicians, or GME as we more commonly refer to it here at VHHA. So this is our team administering the GME initiative, including myself, like I just said, and I will be your primary contact for the initiative going forward. Vicki Humphreys is the grants administrator, so she'll be very busy as you all apply for these funding mechanisms. And Sharon Alexander will support the initiative as the director of the VHHA's workforce initiatives. So as mentioned previously, Homegrown Health Heroes is one of 4 initiatives with a priority to increase the clinical workforce in rural areas across the state. The Attract and Retain Physicians initiative focuses on GME expansion in rural and rural serving areas. And like I just mentioned, while it's referred to as Attract and Retain Physicians in the state's application, we more commonly refer to it as GME. So you may see or hear that throughout the presentation or conversations that we may have with you all. So several clinical areas of focus were identified in the state's application, which included primary care, obstetrics and gynecology, psychiatry, and nurse midwifery. But then through conversation with you all as members, general surgery and pediatrics were identified as areas of need as well. But we also understand that there may be additional specialties of interest because of your unique community needs. So it's not an exhaustive list of specialties that may be funded. So the GME initiative will award up to a maximum of $200,000 per resident annually to cover health system operational costs to implement a GME program, resident salaries and benefits, and wraparound supports to address retention barriers in rural communities. The funding will cover up to 4 years of a residency program. And as of today, our goal is to fund up to 80 slots across 3 cohorts. And I'm going to share a breakdown of the total number of awarded slots per year on the next slide. Applicants can apply for multiple slots and specialties, so there's no limit to what you apply for. And all residents receiving funding through this initiative must complete a 5-year rural service commitment with the residency training counting towards that time period. So this table outlines the projected program funding and residency slot generation over the 5-year RHT initiative. So new residency slots are expected to be added during years 1 through 3, with year 1 having the largest goal of attaining 47 new residency slots. And then funding will continue, the funding in later years will continue to support those residency slots that were added in the different cohorts. Next slide, please. So similarly to what Heather shared regarding eligibility criteria, this is geared towards hospitals and health systems who are legally organized or legally in good standing, capable of receiving federal subaward funding, operate in or provide services to federally designated rural Virginia communities. You must have the active SAM registration, current UEI, no active exclusion, debarments, or suspensions, and demonstrated capacity to manage federal funds. In addition, you must be a hospital or health system that wants to expand an existing GME program or start a new program or track for which you are primary participating hospital site of training. And then for this funding, we're going to have 2 different tiers. That's how we're referring to them. And the first one is residency capacity expansion. So in that tier of funding, you must already have an ACGME accredited program at the time of the application and maintain that accreditation throughout the funding. And then for tier 2, if you're interested in creating a new residency program or track, you must obtain accreditation during the funding period by a specified time and maintain accreditation for that during the remainder of the funding term. So the goal of the GME initiative is to increase rural residents' access to primary care and to create a lasting pipeline of residents in rural locations. So as you can see, the metrics by which the state will will be measured are incremental number of residency positions filled per year and a physician to population ratio in rural counties and fields targeted by the sub-initiative. So the specific targets to measure those two metrics are filling at least 80 residency positions by the year 2030, and then at least a 1 to 3% physician to population ratio improvement within each of the 6 rural health regions by 2030. And sustainability of this initiative would be creating that rural provider workforce that will remain in Virginia beyond the funding period and maintaining the partnerships needed to continue these residency programs. So required activities include implementing resident recruitment strategies, recruiting and enrolling those residents, establishing and maintaining the clinical training partnerships in rural areas, implementing resident wraparound and retention supports, tracking that retention of residents, their graduate outcomes and service commitments, and reporting and performance monitoring. Okay, now I'm going to hand it over to Vicki's to review some of the grant application and process information.
Okay, thank you, Kayla. Now that we've reviewed both funding opportunities, let's turn our attention to the application process. My goal over the next few slides is to help you understand what to expect when the RFA is released. We'll walk through key dates, where to find application materials, the basic application structure, and some important compliance requirements. So whether you're planning to apply for RPM, GME, or both programs, starting preparations early will help ensure a smoother submission process for you. So we encourage organizations to begin these internal conversations now about project scope, staffing, partnerships, and budgeting so that you're ready when the application window opens. Let's start with the timeline here. Can you go back one? Thanks. The year 1 RFA is expected to be released on August the 10th. The applications will be due on September the 15th, which gives you just over a month to prepare and submit your materials. And award announcements are anticipated on or before October 30th, 2026. Because this is a relatively short application period, we strongly encourage interested hospitals and health systems to start planning now, as I said before. Please note that the RFA documents are currently under review by DMAS, and final details will be provided once that review is complete. So as soon as the applications are released, we'll share that information broadly through our communication channels. Next slide. A common question is where to find the application materials once they're released. Well, the RFAs will be available on the VHHA Foundation website, as well as the Virginia Rural Health Transformation Program website. We'll also notify stakeholders through the VHHA member listserv and other communication channels when the application period officially opens. How do you submit an application? That will be through an online submission portal that we've created, and the portal link and the detailed submission instructions will be included within the RFA. So we recommend bookmarking these websites and ensuring the appropriate members of your team are subscribed to receive updates. And this will help you all stay informed about any movements with the program. So although RPM and GME are separate funding opportunities, the applications share several common elements. So each application will require a cover page signed by an authorized organizational representative. Applicants will also complete a project narrative describing their proposed program, goals, activities, their anticipated outcomes. A strong work plan is a critical component. We want to understand your timeline, milestones, performance measures, and expected results. You'll also be asked to provide information about your organization's capacity, key personnel involved in implementation, and your performance measurement and evaluation plan. Budget development is particularly important. Applications must include a detailed budget and a narrative clearly explaining how requested funds will be used. And we'll provide a template for that. Finally, applicants should be prepared to submit some documentation that supports our risk assessment process, including their institutional operating budget and some past year's audit information. Next slide. Let's discuss some important compliance and reporting expectations. Applications will be reviewed by a panel that will include representatives from both VHHA Foundation and DMAS, and they'll be evaluated using a 100-point scoring system, which will be laid out in the RFA. For year one, the budget period will run from October 30th, 2026 through September 30th, 2027. Awards are structured as reimbursement-based contracts, meaning recipients will request reimbursement for eligible expenses that have already been incurred. It's important to remember that spending cannot begin until contracts are fully executed and signed. Administrative costs are allowable, but are limited to 4% of the total award, and these should be clearly identified in your budget. Again, we have a template for that. Awardees will have ongoing reporting responsibilities, including quarterly progress reports and annual programmatic and financial reports. So the intent is, I want to be clear, the intent is to maintain continuous agreements with successful awardees, but future funding remains contingent upon performance progress and continued availability of funding by CMS. Now I will turn the presentation back over to Kelly.
Thanks, Vicki. Before we move on, I have an exciting update hot off the press. The Virginia Healthcare Foundation let us know this morning that the Provider Interoperability RFA, which is part of CARE IQ, is expected to be released tomorrow. This funding opportunity is separate from RPM and GME programs that we've discussed today, but we know many hospitals and health systems are interested in this initiative. The Virginia Healthcare Foundation will host a pre-application webinar on August 6th, and applications will be due August 31st. Award notifications are anticipated on October 1. We'll share information about this opportunity along with future RHT funding announcements through the VHHA Rural Health Transformation listserv, and we'll provide a link to sign up for that in their closing slides today. Thank you. So we've covered a lot of information today. We recognize this is a significant investment and a new program, so we know there's questions. As I mentioned earlier, if there are questions we can't fully answer today, we'll work with our partners at DMAS and CMS to obtain clarification and share information back out as it becomes available. At this point, we'd like to open the floor for questions and discussion. Please feel free to use the raise hand feature to ask your question aloud or enter questions in the chat, and we'll address as many as we can during our remaining time together. If we aren't able to address your questions today, we'll capture it and include follow-up information in future communications. I see a hand raised by Matthew Luce. Hello, friend. You can unmute. Let's see. Is he allowed to unmute? Do we need to allow that? I'm looking to folks on the technical. Oh, there we go.
There it is.
Matthew.
Okay, it works.
Hello.
Hi, how are you?
Great.
Okay, so sorry. In the GME portion, when you're talking about new programs, and you talk about achieving accreditation, ACGME accreditation within a certain time period, are you being specific to full accreditation? Because as you know, ACGME offers various levels, particularly for new programs, it's sort of initial accreditation. Is the Commonwealth going to be specific to the type of accreditation? You know what I mean? Because the timing of things is really outside of our control. It's on the ACGME. So just want to see.
Yeah, I think great question. And yes, I know all about the different timings and when you have to get your item on the agenda approved before the meeting happens and things like that. So year one, because we have to fund things pretty quickly, we'll most likely fill, like our goal is to fill slots. And so programs that are ready to fill slots will be preferential, but if programs are advanced in their stage of preparation to get that accreditation, we highly encourage people to apply. And I think the specified date and time is something that we can communicate about and finalize together to ensure that we're funding things that will result in slots within the time period that we have funding.
Very good. Thanks, guys.
Welcome.
Ben, you're up next.
Hey guys, thanks for having this. Quick question for you. I'm not sure if what I'm going to describe meets criteria for this, but I think it's what we're all going for. So I work in a health system where the main body of the health system is in like a non-rural area. My hospital is an hour and a half south of that in Mecklenburg County. It's as rural as it gets. I'm trying to develop a elective rotation for the pre-existing resident emergency medicine residency program so I can pull residents and create a pipeline for community rural exposure to gain interest in working in this area and to provide a new educational experience. It's not necessarily creating a brand new residency program from scratch, but it is creating a pipeline to a rural area to expand educational opportunities. And I think it'll improve the workforce and interest in working in rural Virginia. And I was just wondering if that sounds like something that would be potentially applicable for funding through this initiative.
I was gonna say, I feel like you've thrown us an idea that we haven't considered yet. So congratulations. But yeah, it definitely sounds like something that would be fundable under this initiative. And like Kelly mentioned with the ruralness, and that's something too that we can discuss about, are you rural serving or in a rural location as well?
Yeah, I drive past an hour and a half of trees to get to work.
Yeah.
And the
Yeah.
one thing, the other follow-up question I have, and I'm sorry to keep your time. Part of the, I think this is something different from what was described in the slides, but part of your thing is like, you have to, after you receive any funding, any resident that receives funding will need to like sign on to work in a rural area. Now, this would mainly be like a 1-month block rotation for these residents to come down. So this is really just increasing exposure and everything else. So I don't think they would be applicable for that. And this may be something that we need to talk to. Like, I'll send you an email about what my thoughts are and we can go from there if that sounds good.
Okay. Yeah. Sounds great.
Thanks, Ben. Nick, you're up next.
Okay, sorry, it took me a minute. Thank you for hosting this again. I think we're all excited to see how we can make good use of these funds. My question was kind of the opposite of what Ben kind of asked, and really focused on, are these residency slots matching what current GME standards are for rural rotations, where greater than 51% of the training has to occur in a rural area in order to be eligible for the funds?
That is not how we are defining it internally, no. So yeah, I know that is not, it just needs to either be in a rural location or you're serving rural patients. And as of today, we do not have a standard percentage of time in a rural location.
Okay, just thinking through it, if residents are not spending that much time in a rural area, it's going to be really hard to get that 5-year payback taken care of. As you're working through applications and what you're doing, just thinking long term.
Okay, thank you for that. We'll consider that moving forward.
I saw Pat Young's question in the chat regarding the reevaluation of rurality. This was a discussion in our recent CMS site visit that occurred earlier in July. We discussed with our project officer and with CMS leadership the definition that was used in the state application and how some areas which are considered non-rural, I think we all know, and recognize the rurality of those communities and the patients living there. So there is an evaluation underway. We don't have a timeline on that. We don't have direct information, but know that we have lifted up those concerns to CMS. And as any changes may occur, we will communicate those back to you. And happy to have individual conversations around specific eligibility, patient populations, percent of rural patients served. We've pulled an extensive amount of data and are happy to share that with you. I see Mohan.
Yes, thank you. I hope you can hear me.
Yes.
I think it's a similar question, but is it only for new residency slots and tracks, or if we were to develop several different residency rotations, for instance, in rural FQHCs that are regular primary care residents and internal medicine would then rotate through? Would that be something that would be fungible, or does it need to be, we're developing like an on-site residency track where they're mostly seeing patients at that rural site?
Yeah, the ultimate goal is to make a more robust residency body across the state. So more bodies filling residency positions. So new slots are definitely the preference.
Thank you.
Welcome.
Bill Elwood. Hello, friend.
All right, there we go. I'm sorry. Can you throw up that slide again about the provider interoperability that you had up there a minute ago, just right there toward the end? Thank you so much.
You bet. And we will be sending that out over our listserv tomorrow when they make their announcement on the RFA. But we did want to, since it was hot off the press, we thought it was great to be able to share with this audience today. Any other questions for our team at this time? Okay. Oh, I see one. Lynn Harris, go ahead. Lynn, are you able to unmute?
There, hi.
There we go.
I had asked in the Q&A about when the webinar slides are going to be available, but I'm wondering, is this whole webinar with all of the content and discussion, is that going to be available like a recording?
Yes. Yes, we will. I'm sorry, I hadn't tripped over to the Q&A. The recording, a copy of the recording as well as a copy of the slides will be posted on our website and will be distributed via our listserv after this.
Great, thank you.
Absolutely. Vera, hello.
Hi. Hey, kudos to the VHHE team for being the first key partner to put out a webinar about, how to apply, some of the timelines and things like that. And this has been a fantastic webinar. I know that you said that the RFA is under review by DMAS right now. Do you happen to know if DMAS is trying to align the format of the RFAs that come out from all care, key partners, or will each key partner kind of have their own format and it's all going to be varying?
Sure. Great question. There is an RFA template that was developed by DMAS that each of the key implementation partners is aligning to. So we'll certainly have different questions related to the programmatic elements, but each implementation partner for each initiative will be requesting the same basic information related to being a valid recipient of federal funds.
Wonderful. Thank you.
Mm-hmm. Any other questions? It's a great group with a lot of friends on the line. So, okay, if not, we will move on. Sharon, you want to pull back up the slides? Next up, so we encourage you to stay connected. Please make sure that you're signed up for our Rural Health Transformation listserv. This is going to be one of our primary channels for sharing RFA announcements, both ours as well as the other implementation partners. We are committed to making sure you have the opportunity to engage in every initiative of RHT that you're interested in. We'll also be sharing funding announcements, technical assistance opportunities, FAQs, and program updates. You can also visit the VHHA Foundation website and the state's RHT page for ongoing information and resources. And if you have questions, please schedule a consultation. We understand every organization is different. Many questions are going to be really specific to your unique circumstances, especially when it comes to GME programs, eligibility and such. So that's why we've established dedicated one-on-one consultation opportunities for both the GME and the RPM programs. Unlike other grants where you fill out an application and you send it out into the universe and you hope and pray and wait, we want to talk to you before you apply. We're happy to talk to you throughout the process. We are committed to getting these funds in your hands for eligible programs. So if you'd like to discuss project ideas, eligibility, implementation considerations, partnerships, procurement questions, or other application-related topics, definitely encourage you to schedule time with our teams. And lastly, I just want to say a big thank you. This has been a massive undertaking and a major team effort. Many of you on the call have played a key role in helping us to develop these programs through your insights and input throughout the process. So we sincerely thank you, Karen, key partner from long ago. So we know the work that you are doing every day is critically important to the health and well-being of your communities. We're honored to partner with you in this effort. As we've stated earlier, a recording of today's webinar and the application materials will be shared with all attendees following this session. I strongly encourage you, oh my gosh, so much love coming through on that chat. This is great. We're going to save that for posterity and we're going to remember it in the dark hours. There is a link for the survey in the chat here, and that will be emailed out to you. Please complete that. It's an opportunity to let us know if you're interested in the other RHT initiatives. Check that box and we will do a personal connection and make sure that you're handed off and connected with the other implementation partners. It's also an opportunity to ask questions there and let us know what your thoughts are, concerns. We want to be your partner throughout. So with that, thank you very much for joining us today. We look forward to working with all of you in the many months ahead. Take care and have a great day.